Okay. Hello, everyone, and welcome. I'm so glad that you were able to join us today. My name is Samantha Lasky. I am with the Illinois Public Health Institute, and perfect. There's the slideshow. I'm with the Illinois Public Health Institute, and this technical assistance session is a part of the working with IDPH to do the Community Health Assessment and Planning Grant. This work allows us to host webinars this year, a series of 4 webinars and 4 quarterly data Q&A technical assistance sessions. So local health departments and folks who work in and around I-plans and community health assessments and community health improvement plans can learn more and get more information about existing data systems, ways to do your I-plan process, ways to improve your I-plan process. And so we're really grateful to have the opportunity today to do our first data Q&A technical assistance session of the year. Mind you, this session is being recorded, so we will have a Q&A, and this session will be posted to the iPlan website following the recording or following this session, and slides will be shared as well. Your training TA, your training TA team today, lots of T's alliteration here, for this session is I'm going to be here to share some initial information. You'll hear from me a little bit, and then I'm going to pass it over to some folks from who are data stewards through IDPH or through Northwestern. Stacy Hoferka is going to be joining us for syndromic surveillance, and Marianne Mason is here from Northwestern to talk about IVDRS and SUDORS data reporting systems. So we're very excited to have them both on the call and to join us. Please note that we will have a Q&A session at the end, so come prepared with any questions you may have, and we appreciate you taking the time today to join us. Okay. So as I said, first we're going to do some quick assessing IDPH data. So just sharing a little bit more about iQuery, how you can access that, how you can utilize it. And then we're going to do a quick introduction to Syndromic Surveillance System and the IVDRS and the SUDORS data systems. If you are on our call, you're calling in from a local health department or a partner of a local health department, feel free to introduce yourself in the chat and share your name, where you're calling in from. We'd love to hear from you. And before we even begin, if you have any questions, feel free to drop those in the chat. We'll make sure to answer them while we get into the Q&A session. So feel free to parking lot those questions in the chat. As I said earlier, our learning objectives today is describing how to access these systems, how to utilize them, what questions do we have. We have information on contacting IDPH about getting access to iQuery and the master data use agreement, and just troubleshooting any questions, having the opportunity to meet with the data stewards and learn more about the work that they're doing. We have the same group agreements as always. The big ones to highlight here are making sure that we take space and make space. If you're somebody who has some questions, but you don't maybe feel comfortable unmuting, we want you to be able to drop information in the chat and share that way. If you are comfortable unmuting when we get to the Q&A session, this is supposed to be interactive. So please feel free to raise your hand or just simply unmute when it's time to ask questions. We know that folks are really busy and that a lot of people have a lot of things going on, but we ask that folks actively participate so we can really get the most out of the session that we'd like to. And don't hesitate in asking questions that you might think, well, people might know this, but I don't know this. This is a learning session for all of us. So we're really excited to have the opportunity to talk with the data stewards directly today. Before we get into it and start with the introduction to syndromic surveillance, we did want to quickly share about accessing data through iQuery and through IDPH. So we have a really awesome new iQuery system. It's beautiful. I can show you like a quick high-level overview of it. Most Health departments, 84 out of 97 health departments have already signed the master data use agreement to receive your login and be able to do this work. If you feel like you don't have that or you're not sure, feel free to contact your administrator at your local health department. And if you have any questions, you can contact the folks here at IDPH, and we'll drop that link in the chat as well. Here, this is a really detailed step to get access to iQuery. And I'll go back to that, but essentially iQuery is we've updated, or IDPH has updated iQuery, and it's the web-based query system for collecting and disseminating the data. So they have a lot of really cool stuff on the iQuery website where you can see visual data representations and accessing the dashboard for the data. They have information on related data and other places and other data sources that you can get to access for your iPlan to learn more about what's going on in your county, your zip code, your area. We have indicators and definitions of those indicators, any frequently asked questions you may need, training materials. Last year we did a whole session on iQuery, so you can learn more about iQuery and hear more about it. And there were a lot of wonderful questions asked there, and you can actually access that training there on the iQuery website. Share data, which is really awesome. It provides access to the health plans to be able to see what's going on in the rest of the state. And this is really an awesome source and should really be your primary source when you're doing your iPlans to access the most up-to-date data possible in an easy way. So it's you can access it through the IDPH website. I'll also drop the link directly to the iQuery website in the chat. And part of what you can do with this master data use agreement, check to see if your administrator's already signed it. If they're not, they can get connected to the folks who can help them sign it. And then you'll be able to request an iQuery login. So you do need to log in to access iQuery. So make sure that you do have that login. And if you don't, you can contact the folks at iQuery. And we have some folks on the line who do that work. Frida Folcom is one of those folks who's in charge of iQuery, who works on iQuery. And then you'll be able to, there's some additional steps, and you'll be able to log in and access iQuery. So we really encourage you to use that as really a primary source for accessing your quantitative data for your iPlans and your community health assessments. And with that introductory information on accessing data and things like that, let's get into some specifics with our two data stewards here, our folks who are really working on syndromic surveillance and things like that. So I'm going to pass it over to Stacy to introduce herself. And thank you so much for joining us today, Stacy.
Hi, thank you for having me, and thank you so much for your help me getting to the meeting. I'm Stacy Hofferka. I'm an epidemiologist at IDPH. I've been with IDPH since 2012. I used to work in the communicable disease section, and I've been in the Division of Patient Safety and Quality for about 5 years. Throughout that whole time, I've helped to establish our syndromic surveillance system. That is a connection we have with the hospitals to send near real-time data for all their emergency department visits and their inpatient admissions. So I've gone into details of syndromic surveillance previously. So the reason I'm here today and why I plan to attend most of the TA sessions quarterly is more to just be a resource to answer questions you may have. But as we're just starting to get a lot more, we're hoping to get a lot more engagement from local health departments who haven't used the system before. I can always do a little bit of an intro, but I need to kind of gauge what people want to know more about. For many of you who are attending today, you might already also be in the middle of our 3-part training series that we're conducting in April. We have a partnership with a team of experts in inductive health, and they've done trainings the past 2 Mondays, trainings that have been recorded, and next week we'll conclude the 3-part series. It can be a lot. It may not hit everybody's needs, but that's why I'm here anytime you need to be, shoot me an email and be like, I just need help with this simple thing. Can you help me? Can you tell me what to do to get started? So that's what I was going to talk about today for a few slides, is just making sure you're aware of like how to get the process started to connect the data, connect access to the data. And then I'm going to have a question for the group, which can be something that we put in the chat, or you can think on for a bit and always get back to me later on. Go to the next slide. That. So sorry. This is one of the main things. Our goal is that every local health department have at least one user. And we understand that there's a lot of other priorities and that your user may not be fluent in the system, but if there's times when the system becomes valuable to you to check out clusters of specific things that are happening in the community, having a local user on site is the first step. So that's a two-step process for syndromic surveillance. And everything pretty much starts with your portal registration authority. That is the person, and there's one at every local health department. There's one at every hospital system. It's somebody who's completed just an extra step of security, signed an additional document, acknowledging that they are within their organization and that they know who their staff are, who the people are that work there, so that when they recommend that we give a user access to the system, they're on site. They know that's a true request for a person. It's not somebody randomly sending. It's just extra security and validation that this person needs access to this data, and the PRA is the responsible person for that. If you don't know who your PRA is, and I've actually learned that a couple of our different systems at IDPH have different PRAs, and I apologize for that. I'd never known that before. We work with the person who is most tightly connected to your communicable disease team. So whoever is doing what we used to call INEDS, which is now the IDSS system, but whoever's doing your communicable disease investigations often knows who the PRA is, because this was initially set up as an INEDS security feature. So if you're not sure who the PRA is, you can find them through talking to your communicable disease team, and they should be able to point you to the right person. And if not, reach out and we will work with you to connect you to the PRA. And then they just enter this link that's on the top of this slide. And they say, I'm the PRA, they confirm that and provide their information, and they confirm the information for the user. So we set up initial accounts in Syndromic, and that gives you aggregate access to statewide data. So you can see what's in your county for different kinds of time trends, some spatial information about a whole host of things that people seek care for in the ED. But also, for example, if it's flu season and you want to see what the picture looks like regionally or for the state as a whole, you can see that on aggregate too. There's a second level of request. The second step in this process is if somebody in your health department should have access to the individual visit level data, like if they are in charge of investigating clusters of overdoses or COVID, or they're looking for measles cases and they need to see the individual records, then once the initial account is set up, that user would go back into the same link. They would say, I need additional details. I need the data details on the individual visits. There's a few simple acknowledgements that they check, and that was established before we did the master DUA, but it takes about 30 seconds. And then we would turn on jurisdiction-specific data access, and that is residents in your jurisdiction that's not care in the hospital, or if you have a hospital in your jurisdiction, all the visits to those facilities. The documentation is pretty familiar with this group, I think. It's after you sign the master DUA, that's agency-wide for each individual health department. Individual users have to sign attachment B, and that's one time for all the data sets that the master DUA covers. But then for Syndromic, if you have users that need access to it, we have a 2-page document. It's really designed for them to understand the data and interpret it correctly, but it also serves as a signature that the individual's user signs, saying they understand how to protect the data security, how to use the data, and there's a host of things that we comment on in that, but it's a 2-pager. It's meant to be like a useful information for this specific data set. I mean, I don't even need to go into the authorities, but this is a mandatory reporting system. Syndromic surveillance is in the admin code. It's in the same place as our hospital discharge data or billing data resides. Go ahead. This is the overview for syndromic surveillance, and I don't want to do this. I don't want to go into this in much detail because I did this on the last call. But just to give you the overview, like I said, the hospitals report to IDPH. We store that data in our hub, so it helps with linkage to other systems. We link it to the XDRO to push notifications back to hospitals that they have patients that should be in isolation or have appropriate contact precautions. We link to the prescription monitoring program. We link to COVID cases when we were working on that. We can link to communicable disease data. And then we send it to two systems. The local instance, what you see there, local essence, it's really the crux of what we're pushing these days. We are making sure that we have sustainability in our system and that our data is secure. The NSSP system is still active. It is the CDC arm of what's supported syndromic surveillance for at least a decade. But things are changing rather rapidly. And the local instance is a little bit more of a place where we have protection and control of the data and can give access to the locals, along with some additional features that we'd like to build in that are specific to Illinois. That's all for this slide. Oh, you don't even, I'm sorry that one's still there. You can pass. That's a really detailed view of what we think is the hub. It's very beautiful. It's artwork in my mind, but not for most people. It does a lot of things. So again, if you are in the training now, you know that we've transitioned to supporting a local instance of Essence. That data, that application includes data from Illinois Poison Control as well, so that you can look at them as overlays. There's a little bit of an issue with local health departments where we have to decide who you sign a data use agreement with, if you have to sign directly with Poison Control or if they'll defer to us and our master DUA, and that's still pending. So I am sorry about that, but for some locals, you'll have to wait until Poison Control has made a decision on that. But they've already been informed that we need to know that. We're also looking at bringing in wastewater data. Right now, that's a lot of communicable disease related data, but we're looking at doing substances related to like opioids and other types of things that are contributing to overdose and the novel emergence of new substances. It does offer some security issues and sustainability, as I mentioned already. You can see IDPH specific regions in the local system, and we are looking at building out just additional customizations, which may be something you're interested in, may not be. I'm about to come up on a question for, I think, those health departments that are thinking they're not going to spend a lot of time in Essence. I want to figure out how to help your jurisdiction as well. Can you go to the next slide for me? So this one is specific to our overdoses. You know, for the purposes of this, I don't think I'm going to talk about this slide. And then this is just resources on things. Actually, there's a lot of things to think about that you can use Syndromic for. And I do have one more slide I built out just this Monday and didn't think about including, but if you're not sure what you do Syndromic for, there's a whole host of things, but you could think it's for influenza-like illness and our respiratory dashboard that does RSV, flu, and COVID, as well as broad respiratory acute trends. We use it for our opioid overdose dashboard. We use it for our firearms dashboard. We are working on a climate change dashboard for local health departments. If your staff spends time looking for rabies, vaccination, health information for those exposed to rabies and are going through the 5-part series, you can search the ED records directly if you aren't able to call the hospital, which takes more time. And then we do a lot of the linkage stuff that I made a mention of earlier. So just to know there's anything people are taking care for in the ED might be relevant to you. Maybe it's mental health related illness and you don't have a lot of other surveillance systems for that. There's surveillance built in for mental health syndromes. There's some syndromes we're building out for disability in the population, which is helpful for emergency response. At the next call, I can join, and if you have questions about specifics about how to use the data or other things like that, you can let me know. I think this is my last slide. Okay, so I'm just going to propose one question to this group, and this has come to me from IDPH staff who are really focused on what to put into iQuery from our various surveillance systems. Syndromic, the way I use it, because it's real time, every minute of the day it's updating with new information. I always live inside the Essence application because that's the most up-to-date information. But for anyone who's looking to go to a one-stop shop in iQuery, and they want some hospital data and some like hospital admissions or emergency department trend data, we can do an extract of stuff that's in Syndromic and potentially put something more static in iQuery. But I don't really know that it's as valuable. So I would probably need some insights from the local health departments that say, when you go into iQuery, knowing we have this live system, but it's separate, what would you want to see in iQuery? And then if I have those ideas from your end and your perspective, I can try to think of ways to extract something from Syndromic and make it available in iQuery. I mean, we do this with dashboards, right? Monthly, we extract data from Syndromic and we put it into the dashboards that are public. So the process would be similar. I just want to understand, what would you be looking for in that system instead of going into Essence? And those insights would help me, because I actually don't think like that with this data. So I have to rely on the local health department needs to try to address them. Well, thanks.
Great. Thank you. Thank you, Stacy. And I think that's actually a good question that we can posit to the group right now. If you have any thoughts um, on her question around what would be the most helpful to include in iQuery, feel free to drop those in the chat or unmute if you have those thoughts, and we can bring that right now. Did somebody?
Right, thanks. Just a quick question, and thank you so very much for the presentation, Stacy. And my question was in regards to how often is data cleaned in Essence, and I know that this might depend on the type of indicator, because again, we had pulled some data in regards to COVID from Essence, and when we got back into the system, there seemed to have been some data cleaning on that front. So
Yeah. So I don't know if cleaning is the right word for Essence, but updates happen all the time. So for example, if you pull especially the most immediate days of data, the longer you are out from it, like say 2024 and stuff, it tends to be more stable. But the more recent data, so what happens is somebody shows up at the ED, and as soon as they present, we get a message and it processes in Essence. But throughout the course of that visit, the doctor evaluates them. They maybe enhance the chief complaint, which is like it comes in and the patient says something. Maybe that triage nurse just checks stomach ache, and that's all we get. But then when they're taken back into the room and they get evaluated further, the nurse types in a more detailed piece of information, and that comes in. And then we might override stomach ache with, I had a fever and been throwing up for 3 days or something. And it might change the way the data gets classified, right? It gets binned into all these different syndromes based on what information comes from the chief complaint or from a diagnosis. And even the diagnosis can get updated, because the system will take the immediate admitting diagnosis, and it will take any working diagnosis that is entered in the patient and the hospital EMR while they're there. And then even a week or two later, and sometimes maybe even a month or more later, when the hospitals do their billing for the system, things do change. The diagnosis becomes, it goes from one thing to something else. And I don't even understand why. There's reasons, I know, but I'm not a billing expert. And then that may cause the visit to be classified differently. And so your numbers will change based on that. So the real-time nature means that the data is always dynamic. So we never really freeze it. So even like data from 2 years ago, if somebody were to send us an updated message, and they shouldn't, it should only trigger on visit-related changes, not patient-related changes, but sometimes we get old data, then old messages would update. So it's never static.
Great. Thank you, Stacy. Patrick, did that answer that question for you?
right, that really answered the question, and I really appreciate the detailed explanation.
Thank you. Any other initial questions? I know there were some questions that came in earlier, and we can probably hold those until the Q&A session. But wanted to see if there were any initial questions from folks before we pass it over to Marianne. Okay. Great. Thank you, Stacy. So you'll have the opportunity to, after Marianne presents, ask both Marianne and Stacy some additional questions. I know we had some come in the registration, so we'll make sure to get to those as well in the Q&A right after Marianne. So I'm going to pass it over to her now to be able to share her screen and present her data system.
Hello, everyone. I'm just getting going with sharing my screen here, and then we will let's see. Okay, is everyone seeing the slideshow version?
Yep.
Okay, I should probably turn my camera on. Okay, hi, everybody. It's nice to be here. I'm kind of an insider outsider person here, and I'll do my best to explain that as we go along. So I'll be speaking today about two public health surveillance systems that I'm the principal investigator for and that are operated out of Northwestern University. And the whole idea of our surveillance systems are that these are data for to inform evidence-based programming policies, planning, and practices. So I'm really, really happy to be able to speak with you today. This, by the way, this picture is Northwestern's newest research center, which I work across the street from, but those who've been to Chicago may recognize that building. Okay, so let me explain a little bit about why I'm sitting at Northwestern talking about IDPH data. It probably is confusing. So we are a bona fide agent of IDPH, which means we are authorized to operate these systems on behalf of IDPH. So these systems and their data are IDPH data, even though we're at Northwestern operating them. So IVDRS is the Illinois Violent Death Reporting System, and SUDORS is the State Unintentional Drug Overdose Reporting System. So these two databases include only deaths. IVDRS has a kind of expansive definition of violence. It includes homicides, suicides, which many people don't think of as violence, but are categorized as violence, unintentional firearm injury deaths, legal intervention deaths, and deaths of undetermined intent. So when the coroner or medical examiner can't assign a manner of death, they go into IVDRS. And then SUDORS is all the unintentional drug overdose deaths. So that's from any substance, an overdose death resulting from any substance. Way back in the very early months of SUDORS, it was focused on opioids, but they quickly expanded that to all substances. And the whole idea is that we're running surveillance on these so that we can provide data to inform your program, policy, planning, maybe your grant applications, things like that. So these are unique data sets. Actually, SUDORS is built in the footprint of IVDRS. So it's very much like IVDRS. It just includes a lot of expanded toxicology variables because, of course, the focus being on drug overdose, there's a need for that. But these are probably the most comprehensive data sets on these types of deaths. And they really help us look at the who, what, where, and when of these certain kinds of deaths. And we're bringing data from a couple of different systems into this these surveillance systems. Some of it is built on the coroner or the medical examiner reports and the death certificates. Some of it comes from the toxicology reports that come back from the coroner medical examiner's office, autopsy reports, but then we also have law enforcement reports, and we get some hospital and EMS data and news releases when they're put out by law enforcement, and all of that goes into our system. And not only do we have structured variables, but we have narratives that kind of take you through the event that resulted in the fatality. So it can tell you what was going on with the person before the fatal injury, what the fatal injury circumstances were like, and any things that were going on during that fatal injury. So it's very comprehensive. It's some very good data. Both of these systems are funded by the Centers for Disease Control. And for SUDORS, we're part of the larger Overdose to Action grant that comes to the state. And for IVDRS, we have a direct grant from the National Violent Death Reporting System. So that's some context of the data. This slide kind of tells you what you could get from these data. And they can be very helpful, especially at the micro or the local level, when you may want to know about what circumstances are going on in your community surrounding these deaths in order to plan for prevention. So obviously it tells you about the manner of death and the demographics of the victim who died, but we also have a lot of detailed information around the circumstances that were going on. Were the victims under the influence of substances at the time of their death? Did they have financial, legal, relationship problems going on at the time of their death? And were they crises, something that happened within the last 2 weeks that precipitated the death? We can tell you what was going on criminally right before the fatal injury. Was there an argument? Was this gang related? That sort of thing. And we can also tell you, for example, if it was a homicide, was there an intimate partner violence aspect to it? We also can tell you where they were before the death. Were they recently released from treatment or jail or prison? Were they in a halfway house? That sort of thing. That can be helpful. And then we have a lot of information about what was going on in the victim's life, just in terms of what was their work like, what was their education, did they have a substance use disorder, did they have a diagnosed mental health problem, did they have a physical health problem? All of those things can be really important at the local level to plan and intervene. So IVDRS has all that. And here's just some more variables we have that are included in the system. So you can really, let's say you're wondering if cocaine is involved in a lot of your homicide deaths. So you can actually look into that. You can know what percent of your victims were tested and what percent of those tested were positive, those sorts of things. It's not on the slide too, but we often have suspect information. And that can be helpful, especially around the domestic violence or intimate partner type of incidents. We can have information about what was the relationship, for example, between the victim and the suspect, things like that. So that gives you an overview of what's in that system. The SUDORS system, again, it was built in the footprint of VDRS. So the data sources are similar, the same actually. And then we have, I think the big difference is going to be around the substance use that was going on that caused the fatal overdose. So we'll have extensive toxicology reports, not only what was on board at the time of death, but also what substances caused the death. A lot of times there are things on board, but they're not at the toxicity level that would cause the death. So you'll have a smaller number of substances involved in the cause of death than just on board. We have a lot of information about how the substance was used and where it happened. Was there a bystander? Was naloxone administered? And if so, by whom? And that can be helpful in terms of thinking about what you want to do distribution-wise and training-wise for naloxone in your community. Again, whether someone's been recently released from a a setting, and then the physical and mental health problems. Again, specific to substance use disorder, we also have their treatment history for substance use. The type of treatment, was it MOUD or something else? Had they had a recent relapse or a recent overdose? And that can be very helpful again in planning intervention. Again, here's some additional variables. These actually, this is a little out of order, I apologize. These are for the suicide circumstances. So there are a special subset of circumstances around suicide deaths that have to do with, did the person disclose their intent to die by suicide to others? Did they have previous attempts, things like that. So that takes you through kind of the content of these data sets. And I wanted to do that because I think these data are relatively new to many of the local health departments. So I hope I gave you a kind of good overview of what's in these data and why you might want to look into them. So we have a rather robust data dissemination and outreach program connected to these surveillance systems. And so we know from our experience that we've been able to help communities identifying common things going on in their communities and who's at risk. Communities have been able to use these data to look at, going upstream, what can we do to prevent and intervene? And then I highlighted this in particular because I know the local health departments do these needs assessments and I-plans, and these can be very helpful for those applications too. So I'm happy to say that there are a number of ways that local health departments could access these data. The iQuery related data section of the iQuery website, if you scroll down that list, you'll see links for IVDRS and SUDORS web pages, which have our recent publications, our data request forms, fact sheets, and links to dashboards. So all of that is readily accessible. So we have an IVDRS dashboard, which is actually published by IDPH, and it's a really cool dashboard. I think the first of its kind in the nation, because not only does it include the violent deaths in Illinois, it also has data on non-fatal firearm injuries through the state's AVERT grant. So it's a really cool dashboard. If you clicked on this link, it would take you to a page like this where you can select different elements from the dashboard to look at. And some of the data are available by county. But I'll give you another option if you want more of the data than is available on that dashboard. But similarly, we have a SUDORS dashboard that is actually hosted on our webpage at Northwestern. We have updated the dashboard to include 2023 data. You can get that from our website, and it has kind of 10 different topic areas you might be interested in looking at. For example, you could look at race and common substances that are cause of death in these overdoses. You could look at your county profile for these sorts of deaths, all of that. So those are available to you just by clicking on links. But you can also put in a request to us and our team for an individualized request that maybe has different combinations of things available than what's on the dashboard. And our webpage has a data request form. And I also put the link up here. And same for SUDORS, we have a data request form, and the link is up here in case you want those later. And at that point, we can customize something for you. We also have 2 community outreach workers who Their entire job is getting data out to local communities. So Kathleen Wasick covers Northern Illinois communities. So she works with counties in Northern Illinois to produce customized PowerPoint presentations, facilitate dialogues, sometimes get you access to case level data. And then Katie Kelly works in our Central and Southern Illinois counties. She does the same thing. They also push our data out through state systems like the Department of Aging and places like that. So you can contact them directly and put in a request to meet and have a discussion about that. And I also wanted just to leave you with some other links. We do about a quarterly newsletter for each of those systems. We have reports and publications available. Our last one was on intimate partner problem related violence. The SUDORS dashboard, of course, we have a LinkedIn profile. We have a link to SUDORS reports. We have one coming out on older adult overdose deaths. That'll be out in the next month or so. And then these two down here, data dictionaries. There's about 600 variables in IVDRS and 900 in SUDORS. So we give you the link to the data dictionary so you can kind of look through and see what you think might be interesting for your locality, and then you can work with us to request those. And here's some other links to various resources available. Again, this is the IDPH dashboard that includes everything, and then some CDC resources that oftentimes groups find helpful. So just thank you for having me, and I guess I'll turn it back over to Samantha.
Thank you. Yes, thank you so much for sharing that information. I've been dropping the links in the chat as well, so folks can see that. And I've dropped some of the links from Stacy too, and we'll definitely be sending slides afterwards. Oh, if you don't mind stopping sharing, Marianne. Wonderful. So with our time left here, we have about 20 minutes or so. I want to leave some space for folks to be able to ask any questions for Stacy, Marianne, are on the call. You can ask them any questions that you might have, things that you want to troubleshoot. Joanne Bardwell and Frida Folcom and Anna Sackhatch are also on the call. So if you have any questions about iQuery, they will be able to answer those as well. So I wanted to pause and give everyone a second and feel free to unmute or drop them in the chat, whatever you're comfortable with. You can ask them to us directly. Okay, as folks are forming that, we have some questions that had come in a little bit earlier. So one question is for Stacy. Someone was describing that they're that they're newer to the process. They've never accessed Essence. So if you could describe a little bit more about what Essence is. Oh, Stacy, I think you're on mute.
Yes.
Oh, there you go.
There I am. Sorry. Yeah, so the Essence data comes to us from hospitals. We don't currently collect from any other places right now, though we're exploring making connections to urgent cares in the future to get more of an outpatient type urgent visit picture of things that are going on in Illinois. But for now, it's the hospitals. They connect to IDPH and they report in, like I said, near real time. Within 15 minutes of presenting, they should be sending the data to us and we should be sending it to the CDC. So within a half an hour. So I actually call the data live these days. It's live data from the hospitals. And it is, yeah, ED visits. And we actually ask them to send us all their inpatient visits too. Not just those that show up at the ED, but those that get direct admits. Sometimes we let them use a little bit of judgment if they also have a rehab center. We're not necessarily as interested in that data, so it may be there, it may not be. Think more of acute needs. Like if people are hospitalized for like acute needs, but it's more severe than an ED visit, we have all that data too.
Thank you. Another question that came through is, you said that wastewater was pending. Could you describe, or do you know how wastewater data can be informative for a community health assessment?
Well, I think that wastewater is fairly untested. It's kind of a newer methodology that started to be implemented by public health departments during COVID. So the utility of it is still a little up in the air. I've seen some success with it from the standpoint of looking at opioids or the byproducts of naloxone and other substances that we don't know to be looking for, potentially showing up in the wastewater where it's harder for us to get a biological specimen tested. We don't have routine testing for overdoses. We're not running labs on those individuals to find out what they've taken. So a lot of the times we need a cluster to happen to do an investigation to find out what novel substances are emerging. And there are a few labs in the country that kind of have their finger on the pulse to do that for us. The wastewater is beneficial because it is in Illinois. And it doesn't involve a lot of contact with human subjects and obtaining specimens from them. It does cover I believe the wastewater sites cover just about all of Illinois at this point. So that's beneficial to us. Right now, they've been using it for communicable disease for a few years, testing for COVID, testing for a couple of other communicable diseases. So I haven't really thought so much about whether or not that's yielded a lot of benefits. I think it'll be more beneficial for some of these other types of testing. But the way we envision using it for syndromic is that it's kind of a correlation. So if you see something spike in the wastewater, but you're not sure what to do with it, then you go check another data source to validate if there's really something to respond to. So like if you saw novel substances in your wastewater, but you don't see any increasing trends in the ED where people seem to be experiencing unusual symptoms with their overdose, no one's reporting these things, then maybe you have a very early indication that something will eventually get detected, or you have the reassurance that it's not a more widespread problem, that something was detected in the wastewater, but it doesn't seem to be affecting human illness. So right now it's kind of like more of like a validity. Like if it triggers something, we investigate further. Wastewater by itself isn't really a standalone surveillance yet.
That's really interesting. Thanks, Stacy. This is a question for both Mary Ann and Stacy. How can the data, or do you have examples of how the data can be used in your systems to inform our work in conducting community health assessments? Do you have any examples? And this is for both.
Sure. I've been talking a lot. I can keep talking, or Mary Ann, did you want to go first?
I can go. There's a lot of ways we've seen communities use our data. One has been to inform setting up domestic violence fatality review teams, which public health is, of course, key to. Another is use in the community needs assessment in terms of the burden of problems and circumstances around them. We've also helped communities figure out service areas and resource allocation of services they're partnering with non-government organizations for. And we've also, we've used the SUDORS data to work with communities to develop a door-to-door intervention in high impact communities. So there's a variety of things we've been able to do with and for communities. We've also been able to use the data to facilitate planning discussions within communities about what resources they want to pursue in terms of grants and grant topics for prevention and intervention. That's been really interesting work for our team. So over to you, Stacy.
So I know the community assessments can be relatively broad. You have a lot of different topics that you're trying to cover. So in some ways, there's a lot of different areas syndromic might be helpful. Think about it in terms of whatever somebody can be seen in the ED for is potentially captured in this surveillance system. And it might be the only place that the surveillance is captured. So, I know that I've sort of been seeing, like sometimes we look across I plans and we see what some of the new strategies are, and there's a lot more focus on types of resources for things that are not communicable disease, which I think is always the traditional thing that local health departments start with. But things are revolving around substance use and revolving around mental health conditions. And I don't think we have a lot of great surveillance data sources for that. So this is a way to characterize those types of issues in your community. There's, in addition to mental health data that's collected, there's also through AVERT, which I know Marianne mentioned from the firearms data, we're grant funded to do some validation on how good Syndromic is for collecting firearms related ED visits, and also the mental health related ED visits, but also looking at violence situations. So there are syndromes already built into syndromic surveillance for sexual assault, intimate partner violence, child abuse and neglect, but I don't know if they're going to be great data sources. Like that's part of the AVERT grant, is that we find out how good is the surveillance system informing those pieces of information, and they may not be good for prevalence, but they might be good for trending if you need to show sort of an increase in certain months of the year. Certainly gun violence increases on certain months of the year, so you can anticipate how that factors into community assessments and what kind of responses you might need to have. But there's a lot of other injury things that have been unexplored. So there's motor vehicle incidents, bike incidents, pedestrian incidents. There are some ways to look at chronic disease. It's not been the most common use of syndromic surveillance previously, because chronic disease is probably better captured in other systems where people have routine healthcare visits and it's more of an outpatient service than it is an emergency service. So again, it may not be good for prevalence, but you can look at trends. You can try to get a sense of like how many people are seeking ED care for things like asthma, diabetes, cardiac issues, respiratory issues, because all the data now is actually, like we've always captured the data in these categories, right? We call them syndromes, which means we take the raw chief complaint and we bucket it into like these categories. Well, now we have hundreds of categories for how we categorize a visit. And every visit isn't just like categorized as one thing. It's not mutually exclusive. I can't be like, this person is absolutely here for this reason and nothing else. Some people get categorized into 10 different reasons, depending on what kind of information we get on that visit. But if we can't categorize it well from a chief complaint, if that's limited, all the ICD-10 codes are also pre-categorized outside of syndromic. They're just categorized into big chunks. There are like chapters, and then there are sections, and there are these things called the CCSR, which I can't remember what it stands for, that take all the visits, and we get 16,000 visits a day, and we'll take the diagnoses codes assigned to those visits and bucket them. So you could use that type of categorization for a lot of chronic disease information. Again, getting to know syndromic is getting to know that it's maybe more for trending than it is prevalence. So how it will help inform your community assessment might be limited. In lieu of there being no other surveillance for an important issue, it's definitely better to have it than not.
Great, thank you both. Any other questions? We have a couple minutes left for some more questions. Feel free to unmute, raise your hand. No need to be shy. I have one more question that came in from the registration, and that's for Marianne. You noted that you can collect data, demographic data on age, gender, race and ethnicity, and marital status. Will the system is the system able to collect data on other demographics outside of that, such as like education, employment, things like that? And is that something that, if not, is it something that you are working on to get more, or religion, I think was another one, demographic data? Oh, you're on mute.
Sorry, we don't collect data on religion. We do have data on marital status. which can be helpful in terms of if you're thinking about who to reach out to in terms of survivors or prevention messaging. It can be helpful to think about who's around the population at risk. We do have education level, which can be helpful in terms of making sure your prevention materials are graded for the literacy level that's appropriate. We do have occupation, which can be helpful just in terms of, again, reaching out to different sectors with prevention messaging, things like that. I think that's most of it. We do have, I guess, immigration status in terms of who's foreign born and not, which again could be useful in terms of reaching out and offering services and supports.
Thank you. It looks like we have about 3 minutes left. So if anyone has any other questions for Stacy and Marianne, feel free to unmute or drop them in the chat with our couple minutes left. As folks might be doing that, I also wanted to say thank you to Stacy and Marianne for joining us today, answering our questions, talking us through the work that you do. This is really awesome work, and I love to see all of this data and all these systems in place in our state. So that is great. Thank you so much for that. For if there are no other questions for other folks, everyone else on the line, if you have any other questions, come in later. If you have things that you didn't think about initially and you thought about later, feel free to email me and I can field those questions to Stacy and Marianne. In the meantime, before you hop off, please, 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 I'm launching a Zoom poll with our evaluation for this session. We have 3 more of these sessions coming up, and we really, really, really want to make sure that these are helpful for folks. So please fill out the evaluation. It's only a couple questions. It only should take a minute. So in this last 2 minutes, if you could take some time to do that. And we appreciate you joining us today, and this session's recorded, so we'll send the recording and the slides and materials in our follow-up. So please take a minute before you hop off to fill out this survey, and I will appreciate you more than you will ever know. Speaking of data. So thank you, and thank you again to Stacy and Marianne for joining us.
Thanks. Goodbye.
We still have 1 more minute, so I appreciate the folks who have stayed on to take this evaluation for us. And feel free once you take the evaluation to hop off. Thank you so much, everyone.